When you look at the very early days of infant cardiac surgery and the reason for the high mortality, it was often due to a misdiagnosis. So they would open the chest knowing that there was one disease, but they would find another defect that was unsuspected. So the reason that echocardiography was so important in this was that it detected some things that had been missed before. So by cardiac catheterization, if they only looked at the right side of the heart, there may be a lesion on the left side of the heart that would be missed. So even in the most primitive days, echo might see that the left heart was too small or that there was a valve abnormality that hadn't been suspected because it was in the presence of cyanotic heart disease, for example. When we first started, we were using a pinpoint-like imaging technique. So I've described it as trying to describe the inside of a cave with a pin light. So we would only see one tiny little portion at a time, but we could see it move. At that point, we used a lot of physical diagnosis and we relied on the EKG and a lot of other parameters to come up with a general diagnosis. But it wasn't definitive enough so that the surgeon would operate based on that alone. So it was only when we had two-dimensional echo, and as we developed the transducers and the scanning and the types of approaches, looking from below, looking from above, looking from the front of the chest, so that we had a total view of the heart, that began to supplant cardiac catheterization as the diagnostic tool, and cardiac catheterization then was used to add to that diagnosis or to do more interventional kinds of studies.